Welcome to Delaware Health Care Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Health Care Reality.
Hi, this is Dr. Nick Biasotto. I'm the host of Medical Society of Delaware's podcast, Delaware Health Care Reality. And today we have two guests on a very interesting topic and somewhat controversial, and it is called medical aid in dying. Before I get into introductions of our guests, I'd like to give some props and kudos out to some of our Medical Society staff that have been helpful to me and our producer, Tom Minton, in getting our podcast together and helping with me on my research of the subject. That is, our staff members are Katie Hamilton. She's the one that coordinates our podcast and gets our guests set up and times for coming in, and Miss Lynn Robinson, who is my assistant in research efforts on any subject that we talk about, and of course our producer, Tom Minton. Today our two guests are Dr. Robert Varipapa and Dr. Michael Vest. Dr. Varipapa is a board-certified neurologist practicing in Dover, Delaware, 35 years or more, and is affiliated with the Bay Health Medical Center. He received his medical degree from the University of Maryland School of Medicine, and he did his residency in neurology at the University of Maryland also. He's very well known in the Dover area for his specialty in helping people with neurological problems. And some of his expertise are in migraines, strokes, Alzheimer's disease, and multiple other neurological problems in the cerebral vascular area. And our second guest is Dr. Michael Vest. Dr. Michael Vest is a graduate from the University of New England College of Osteopathic Medicine and then completed his internship and residency in internal medicine at William Beaumont Army Medical Center in El Paso, Texas. He practiced general medicine in the United States Army for 4 years, including deployment to Ramadi, Iraq, for which he received a Bronze Star Medal. He then went on to complete his fellowship in pulmonary and critical care medicine at Yale University in New Hampton, Connecticut. After his fellowship, he served on the Yale faculty until he was recruited by Christiana Care. That's our hospital in this area, where he is currently focused on care of patients in the intensive care unit. He is involved with medical education, having authored more than 25 peer-reviewed publications, and serves as Associate Professor of Medicine at Sidney Kimmel Medical College of Thomas Jefferson University and Clinical Associate Professor of Medicine at the Philadelphia College of Osteopathic Medicine. Welcome, you guys. It's nice to have you here today.
Thank you for having us.
Dr. Varipapa will be doing the pro, or the point, for medical aid in dying, and Dr. Vest will be discussing the anti or counterpoint on this subject. But before we start, a definition. Medical aid in dying occurs when a physician provides the necessary means and or information to facilitate a patient's choice to end his or her life. Many terms to describe this are death with dignity, doctor-prescribed death, right to die, medical assistance in dying, and doctor-assisted suicide. Okay, so each member will get up to 15 minutes to discuss their point. We will have a break between the two, and we can come back for a general discussion. Dr. Varipapa, you are on for the pro medical aid in dying, so give us your reasoning. Thank you.
Thank you, Dr. Biasotto, for allowing me to speak today about medical aid in dying. I'm going to shift the conversation more towards patient autonomy and choice, as well as provide an overview of medical aid in dying. In my neurology practice, I see patients every day who are dealing with end-of-life decisions. My task is to educate them about options. Do they want to be resuscitated if they collapse at home or have a terminal condition? Do they know the difference between lifespan and health span? And maybe most importantly, have they talked to family members about their end-of-life decisions? Let me tell you my own story. My wife, of 32 years, passed away 5 years ago from ovarian cancer. The disease ravaged her GI tract, making it difficult for her to maintain nutrition and perhaps more critically absorb pain medications provided by hospice. Eventually, she was placed on patient-controlled analgesia, or PCA. But as her condition deteriorated, she lost the lucidity needed to manage her pain effectively, and she passed away 5 years ago. Nancy and I had a solemn agreement not to prolong each other's lives in face of a terminal illness. We discussed medical aid in dying, but since it was not legal in our state, she worried about the risks it might pose to my medical license, or worse. Before she died, I made her a promise. I would work to see medical aid in dying legislation enacted. In healthcare, autonomy is a fundamental ethical principle. It means that individuals should have the right to make informed decisions about their own medical care. That includes accepting treatment, refusing treatment, and, when legally available, choosing medical aid in dying. For many patients, the question isn't about dying, but rather how they live their final days. When terminally ill patients request medical aid in dying, they are often seeking control, dignity, and an option that aligns with their personal values. This makes the conversation about patient rights and autonomy rather than the act of medical aid in dying itself. Medical aid in dying should be viewed as one option among several, including palliative care, or managing patients' symptoms to improve comfort, hospice care, providing support for terminal patients in their final months, advanced directives, which are legal documents ensuring patient wishes are honored, and mental health support, or addressing emotional and psychological concerns. In fact, in places where medical aid in dying is legal, we often see improved palliative care options because more attention is given to end-of-life care as a whole. The goal is not to just legalize medical aid in dying, but to ensure all patients receive compassionate care that aligns with their needs. The conversation about medical aid in dying is often misconstrued. Supporting patient choice doesn't mean advocating for medical aid in dying. It means ensuring that individuals can make their own independent decisions without unnecessary barriers or coercion. Hospice care and medical aid in dying are not contradictory. According to Dr. Lonnie Shavelson, dying is a process, not a moment. It varies in time and quality and how it happens. Let's take this comparison. Just as we respect a terminally ill patient's choice to fight their illness aggressively, we should also respect those who decide that further treatment is no longer aligns with their values. This is about providing options and not pushing an agenda. Some argue that medical aid in dying contradicts the physician's duty to preserve life. Others worry about the slippery slope where medical aid in dying could be misused. These concerns are valid and are carefully addressed through the safeguards in House Bill 140. Oregon has allowed medical aid in dying since 1997, and the slippery slope has not materialized. Here are some recent statistics from Oregon. In 2023, 560 people received prescriptions under the Oregon Death with Dignity Act, and 364 people died from ingesting prescribed medications. This is out of a total of 42,000 deaths in Oregon, so less than 1% of people in Oregon took this option. Most patients died at home, 88%, and most were enrolled in hospice, 87%, versus in Delaware, where hospice enrollment is about 55%. There were no referrals to the Oregon Medical Board for failure to comply with reporting requirements. The three most reported end-of-life concerns in Oregon were loss of autonomy, 92%, decreasing ability to participate in activities that made life enjoyable, or 88%, and loss of dignity, 64%. Autonomy means that one person's moral beliefs should not dictate another person's medical choices. Legislation allows for doctors to opt out of participating in medical aid in dying. Medical ethicist Thaddeus Pope has suggested reviewing recent data and experience with medical aid in dying legislation, looking into issues such as permitting non-physician professionals to engage in medical aid in dying services, which is provided in Delaware HB 140. He also suggests shortening or waiving waiting periods and removing residency requirements. So what's the takeaway? The debate is bigger than medical aid in dying itself. It's really about whether patients have the right to make deeply personal choices about their own bodies and medical care. Some will choose aggressive treatment until the very end. Others may opt for palliative care or hospice care. And some may choose medical aid in dying if it aligns with their values. The key is that each of these choices should be available and respected. Supporting patient autonomy means ensuring that everyone can make an informed decision without judgment or unnecessary barriers. There is a deep deficit in our communication with patients. Many times a doctor will say, "There's nothing more we can do." This is the last thing that you should tell a terminally ill patient. There is always something we can do to help the dying patient. That is really the definition of palliative care, and continuing hospice care is an important part of the process and not contradictory to medical aid in dying. Some books to consider to look into this further. Medical Aid in Dying, A Guide for Patients and Their Supporters by Lonnie Shavelson, originated from questions, interests, and needs of dying patients, their families, and supporters, with the goal of demystifying and facilitating the process of medical aid in dying. The Death Doula's Guide to Living Fully and Dying Prepared, an essential workbook to reflect back, plan ahead, and find your place on your journey by Francesca Lynn Arnoldi, is a workbook that guides you to process your life and legacy, create remembrance projects, build connections to vital supporters, and draft your wishes and plans for your next chapter in life. At its core, this conversation isn't about promoting medical aid in dying. It's about protecting choice, dignity, and patient rights. When discussing end-of-life care, we must ensure that autonomy remains at the forefront and that options are available for those who need them. What are your thoughts? Should patients have more control over their end-of-life decisions? One more thing. I'm going to put a transcript of this commentary along with references on my website at deldoc.com. That's deldoc.com. Thanks for listening.
Thank you, Bob. First, my condolences on the loss of your wife of 32 years. I will have questions for you after. We will shortly go to Dr. Michael Vest for his opinion on medical aid in dying. But why we are discussing this is because legislation today in Delaware is set to either approve or not approve this process. It's part of our legislative package that is down there now, and they're debating it in Dover whether they're going to approve it or not.
Just to give you an update on that, it's gone before the House subcommittee and was approved by the House subcommittee, and now is going to go before the House to be voted upon, probably sometime in the next weeks, I would imagine. Mm-hmm. And then if it is approved by the House, then it would go to the Senate for approval. If the Senate approves it, then it would go to the governor for signature.
I gotcha. Okay. But right now we're going to take a quick break before we introduce Dr. Michael Vest and his feelings on this subject. Also, I'd like to thank everyone who has tuned in to our podcast. It's just come to my attention that they're picking us up in Germany, India, and England, and we have some feedback from them, and it seems to be very positive. But again, the show is working, and I'm really proud to be part of it. Time for a break.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Okay, we're back from our break, and now we're going to discuss with Dr. Michael Vest the counterpoint to medical aid in dying. We are discussing that here today, And as mentioned earlier, legislation is being considered in Dover to approve this, and then we would become the 12th state to approve it, along with the District of Columbia. We have 11 of them now that approve it, and the District of Columbia. Okay, Dr. Vest, Mike, take it from here. Counterpoint.
Great. Thank you for having me. I'm opposed to the legalization of medical aid in dying. My background, as you kind of described, is I have some experience doing general internal medicine. When I was doing that, I was involved in the care of my patients on hospice. And as a pulmonologist, the same thing. And in the ICU, we unfortunately have a lot of patients where we work with them at the end of life. So I've spent a lot of time at the bedsides of patients who are dying and a lot of time talking to families of patients who are dying. One of the things, these are really hard situations with really difficult dynamics. And as I kind of went into this and looked through it, I came to the conclusion that this should not be legal, not because this is something that I'm horrified by that I would never do, but it's something that I could see myself being very easily tempted to do. But as I learned about it, I realized that the problems that my doing it would cause are far more than what they would solve. I got interested in it a lot because of the terminology. And when you talk to patients at the end of life and you talk to their families, especially when we talk about withdrawing life support, they often look at you and they say, "You're suggesting killing my mom. You want to kill her." And there's a lot of misunderstanding between what's the difference between taking away life support or not starting life support. What's the difference between treating symptoms and how is giving morphine for dyspnea different than giving drugs with the intent of having someone die? And those are very different things to us as doctors, but to the patients they can be very confusing. And the terminology of medical aid in dying can be a little bit confusing too. Certainly, the Canadians talk about, hospice, euthanasia, and deliberately giving medications to end the patient's life with the patient taking them, which I like to refer to as assisted suicide, and that's what Derek Humphreys, who started the movement in the U.S., referred to it as well. But I know it's become unpopular on the pro side to use that term, so I'll try to avoid it during the conversation, but I might slip back to it. As I started digging into this and trying to learn about it, I really did dig into the Oregon reports, because since 1998, Oregon has legalized medical aid in dying, and they have the best data, but they have a lot of missing data too. And one of the things that Bob mentioned is they do try to get some information about why the patients decided to do this. And they get this from the doctors who prescribe the lethal drugs. They ask them, they have a survey, and the doctors ask the patients about why they're doing it, and they have some options on the survey, and then they report that back to the state. And one of the things, and you can have more than one, so that's why they don't add up to 100%. But one of the things that really jumps out of that is you see over the years an increase in the number of people being concerned about the cost of medical care and choosing, this way to end their life because of that. Going from like 5%, when they started, up to 8.2% in the most recent data, which is from 2003. And a significant number, about 47% overall, report a big concern of being a burden to family and caregivers. So a lot of the concerns that the patients have is I don't want to be a burden, and I don't want my family to go broke based on my medical care, and those reasons really give me pause and make me say, gee, are we setting up a situation where people who are disadvantaged are going to be hurt by this? And I think that's playing out in Oregon and playing out in other states. And the National Council on Disabilities, which is a federal agency that was set up in 1978, and like a lot of federal agencies, one of the things they do is generate reports. And you can Google, National Council on Disabilities, dangers of assisted suicide laws, and you should get their report to come up fairly easily. But they documented a lot of the cases and problems with it. And one of the cases they describe is a Barbara Wagner, who was in Oregon, and she was a lung cancer patient, which as a pulmonologist is kind of near and dear to me, with an advanced incurable lung cancer, who was denied a drug called Tarceva by her insurance. And Tarceva is an EGF, epithelial growth factor receptor inhibitor. And these are, they do not cure cancer, but they give an amazing improvement in quality of life, an amazing bump in your duration of life when they work for patients. When they came out, we'd see patients with a CT scan riddled with tumor. They get the EGFR inhibitor, and it just goes away on the next CT scan. Eventually, it comes back, but really dramatic effect. And what Oregon did is they denied this drug, but they, in their denial letter, they said, we'll pay for assisted suicide if you'd like that. So there's definitely, you have a situation where this becomes, for someone who doesn't have a lot of money, the cheapest option. And a lot of people do want to leave their kids, some inheritance, and, seeing it all burnt up at the end of life is something that people really fear, legitimately so. The other thing that really jumped out at me from the Oregon report is how rarely any sort of mental health consultation happens. So they track that in Oregon too, and in 2023 there were 3 patients, which is 0.8% of the total patients who died in the Death with Dignity Act who had any sort of mental health consultation. And that really jumps out with me, not because of the question of capacity, but because of the question of untreated comorbid psychiatric disease, which is really unrecognized and really high in our end-of-life patients, up to 75%, as low as 25%, but much higher than 1%. A lot of patients are having depression and anxiety, and these are things that really do respond to treatments that we have, and even if you don't have a lot of time left, you really get benefit from getting treatment from them. So the fact that people aren't getting that really was another thing that sort of raised a red flag for me. The other thing that raised sort of red flags and caution for me with this is, as I listened to, people from the public advocating for it, and I listened to the stories, what I realized is that many of their stories are about people who will not qualify for aid in dying under House Bill 140 because perhaps they had dementia and didn't have decision-making capacity, or perhaps they had diseases such as bowel obstruction that wouldn't necessarily allow them to absorb a medication that was needed to be given through the enteral tract. So there are a lot of reasons why people who think that maybe this would help a loved one that had a horrible experience, when you look at it, really wouldn't potentially even be a candidate for it. And I think that's the reason that you do see a push towards expansion afterwards, which is really, it makes sense. It almost seems, well, if people are advocating for it and it's not actually going to meet the situation that they're describing when they're advocating for it, of course they're going to continue to advocate to change it to actually fit those requirements. And we've seen that in Oregon. Oregon's reduced the time people have to wait after making the request, oftentimes put up as a barrier. The courts ruled that the Oregon requirement that you be a state resident violated the U.S. Constitution's Commerce Clause. So that was thrown out, and Oregon kind of changed their law to comply with that court ruling so that you no longer have to be a resident. California failed to pass in 2024 Senate Bill 1196, which is worth Googling too. So California Senate Bill 1196. And I don't know if they've introduced it again, but I think they're expected to. But it would allow IV medications, which, again, makes perfect sense. Because if you have people who are describing cases where they're not going to absorb enteral medications, it makes sense that they would advocate for IV medications. And really the biggest thing with it that really jumps out is it changed from saying that you have to have a terminal illness, or it would have if it passed, to you have to have a grievous and irremediable condition. So basically a really serious disease, but not necessarily something that's terminal. And that kind of starts to address the issue that people have with things like dementia, right? I have capacity but I have a serious disease, but I don't have a terminal prognosis yet. It's certainly not less than 6 months. So that's what they're trying to do in this California bill. But that, which again gives me pause in terms of the number of people who potentially, would be affected by that. But it also makes very logical sense. In Colorado, there's a internist who wrote a really well-documented paper in the Journal of Eating Disorders describing her experience helping 3 patients with anorexia nervosa end their lives with medical aid in dying. And this was not someone who was cavalier about this. This was not someone who was doing something completely crazy. She was very careful about it, very thoughtful about it, working with these patients who were really suffering and really had a very difficult situation. And before doing this, she actually even checked with the regulatory authorities in Colorado to sort of get their blessing that she was doing something that was okay. And it's one of these things where, like I said at the beginning, that it's a really hard case, and you can see where you'd be tempted to do it and where you'd say, boy, this person's really suffering. I have to do this, and you end up doing something that maybe causes more harm than actual good. And I think that her cases, the way she describes them, and the care that she took to make sure that the I's were dotted and the T's are crossed, really show that this is something that I would expect to happen in a state where these laws are passed, because it makes sense, it's logical, it was well thought out. When I look at House Bill 140 itself, Delaware's House Bill 130, a lot of things about that in particular give me pause, even though it's it's similar to a lot of these other states' laws, like Colorado and Oregon, but the lack of things like training and the lack of things like any funding for the oversight give me pause when I look at what's happening in the other states. And as I go to groups like there's a Academy of Aid in Dying Medicine that has like some CME courses online, and they actually have some lectures that are free that I've watched. And as you go through and you learn about the nuts and bolts of doing this, what you realize is that this is hard to do. You think that killing someone would be easy, but especially if you want them to die peacefully and you don't want them to have a bad death, it's a little bit harder than you'd imagine. And one of the things that one of the speakers that they had really emphasized is you should have a mentor or a preceptor or someone kind of walk you through these cases. And the lack of that in Delaware, in spite of the fact that we have them, requiring us to learn about Alzheimer's disease and child abuse, which we all had in medical school, you have something that we've never had in medical school that they're not requiring anything for. And in these other states, it's really hard to know what's actually going on just because they're not collecting the data. Oregon's doing the best, but in Oregon, there's 100 people who from 2023, they can't confirm whether those patients are alive or dead. So they have that's a high percentage. It's about 18% of all their prescriptions that they don't know what happened to them. And they report, for example, that 5% outlive their 6-month prognosis, which is great, but that's not counting that 100. We don't know if they lived or died or anything. So there's a lot of missing stuff, and if you want to do it right, you really need to provide appropriate resources to places like the Department of Health to do that sort of work. So I think I've probably talked for a little while anyway, and I'll probably end here, and we can have more discussion.
We're going to have a general discussion now. It was very interesting on both of you guys. Thank you. Well, I think it's time for a break at this point, and we'll come back after the break. Thanks.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Hi, again, we're back. This is Dr. Nick Biasotto, host of Medical Society's podcast, Delaware Health Care Reality, and we've been speaking to Dr. Varipapa and Dr. Vest on medical aid in dying. Both of you guys were quoting Oregon data, and I looked it up myself, and it suggests that patients elect medical aid in dying because they're concerned about, one, losing autonomy, as you mentioned, Bob. 90% said that. And less able to engage in activities of life that are enjoyable, that's 89%. Some fear the loss of dignity, you mentioned that, is 74%. And being a burden on the family and the caregivers, either financially or just a burden in general, is 44%. And lastly, losing bodily functions, 44%. Only 25% gave inadequate pain control as a reason for pursuing lethal injection or medical aid in dying. My concern of one of these things is when I have a patient that is terminally ill and suffering from pain or whatever, and requests from me the ability to take her life, can you give me something to end my suffering? I feel the pain of that. I feel the pity for the woman or the person involved. What would be the process if I don't want to do that and I'm not in favor of it? Will there be a process of getting someone to perform that action? I know the state is asking for 2 doctors to approve the fact that the patient is terminally ill and has 6 months or less to live.
Correct.
And is suffering from pain. So I am not going, I feel like, let's say I feel like not being the doctor to do it. Will there be someone that will? And how will they set that up? And who will be I hate to put it in this frame of mind, but who will be the hangman, you know?
So when the Medical Society did their survey a number of years ago, one of the questions they asked was what percentage of doctors would be willing to participate in the whole medical aid in dying process. And if my memory serves me correct, it was about 25% of the respondents. So from that survey, and granted it was a small survey done a number of years ago, it seems to me that there are enough doctors in the state that are at least willing to engage in this process.
Okay.
I can add a couple of things to it. It's 2 providers certifying that the patient is terminally ill. So it could be you and your nurse practitioner together. I don't think it requires anyone to be in a different practice or anything like that. So it could be the same practice.
So the family doctor who's been taking care of them could be one of the persons.
And the nurse practitioner working for the family doctor could be the other one.
The nurse practitioner can have that ability to also do that according to our laws.
Yeah.
Okay.
The other thing, of course, I mentioned, of course, that when you get a request like this, it's certainly sort of a cry to explore further what's going on in terms of, what's going on with your symptom control. Is there something that, we need to do interventionally to help her? Is there something differently that you can do medically? What's kind of behind the request is something that's going to be super important.
I sometimes wonder, I've had patients in hospice because I'm a big believer in hospice towards the end of life. And I'm still in charge of the patient through the hospice. They ask me what to do, what to give them for certain conditions or what they're feeling. And then we have that patient who, is in pain, severe pain. We up the morphine a little bit, okay? Did it help? No, she's still in severe pain. We up the morphine. Oh, did it help? Well, still. Eventually you get to a lethal dose of morphine through instruction through hospice to put the patient at ease. In other words, medical aid in dying to a degree, is it not?
I would say it's not. And I think that goes back to, when they talk about this principle of double effect, in the sense that, like, if you're trying to treat someone's pain and you end up causing respiratory suppression from morphine and they die, that is different than if you gave them the drug with the same intent, with the intent of having them die. But also, these patients get very tolerant of the opioids as you're treating them, and they need very high doses oftentimes in order to achieve adequate pain control. And they've done studies looking to see, like, if I'm really aggressive with pain control and using these high doses of opioids, do I hasten death compared to, say, if I left them in more pain? And they don't. Overall, it doesn't hasten death when you do that. When you look at what the people doing medical aid in dying have to do to try and cause death. It's not just a high dose of opiates. I mean, you're combining a high dose of opiates with high doses of digoxin, with, high doses of barbiturates, with, lots of different drugs, because it is, if you really have the intent of having them die, like I said, it's not as easy as you might think.
Exactly. I think there have been failures, Bob. There have been failures, for example, in the administration of medications, and they did not cause the death of the patient. That's a tough that's a tough point at that point. What do we do now? I often say fentanyl is everywhere. I mean, now it's a Schedule. They're trying to make it a Schedule 1 drug. But if you touch fentanyl, if you just, less than, 10 grains of this stuff, you're dead. And it's a peaceful way. You just fall asleep. Why don't they make fentanyl and the drug to end the life, if it comes down to the passage of this in our state, make fentanyl the drug to be able to do that? Because there's pretty no failures with fentanyl, is there?
Well, many of the fentanyl overdose patients end up in the ICU.
Okay.
You overdose and you do get rescued, and some of them we actually get an okay outcome if someone got to them fast enough, but you might end up with the exact opposite of what you want, where you overdose and you end up in the ICU having a more prolonged death and an agony. You didn't want your family to have a burden, and they had the burden of withdrawing life support or something. So it could be the opposite of what they want.
Go ahead, Bob.
So I'll make two comments on some of the things you just said recently. Number one, I would ask, what's a better situation? That you have a patient in hospice and that you're giving them more and more morphine to the point that they pass away and die? Or is it better for the patient to discuss what their wishes are and say they want medical aid in dying, to have the same outcome with patient approval and patient acceptance?
That's a good question. It's a difficult one to answer, I believe, but it's a good question.
Well, I think it's an easy answer. I think it's easy to say that I would want the patient to make the decision.
So many
as to what they
patients
want.
at that point are unable to make
That's
that
why you
decision.
That's why you need to. Just like the problem with palliative care is the palliative care doctors and I'm sure Mike probably sees this. The palliative care consult is done at the last possible minute when the patient's on their deathbed. Palliative care should be instituted early while the patient's still conscious and awake and can discuss what their options are and what they want to do.
I had placed people in hospice a couple of years before they expired, but they had that terminal illness that,
right.
They were at least in touch.
Well, you're in the minority. I mean, I recently had a family member that was in a hospital in I think Roanoke area, and basically on their deathbed, and they called me and said, "What should we do?" I said, "Well, the first thing you should do is ask the hospital to have a palliative care consult." And they got back to me and said, "Well, we don't have a palliative care physician."
Ooh.
So that's certainly something that needs to be looked into and improved hospital-wide to get palliative care doctors involved early and not at the last minute.
Gotcha.
The other comment I think about the failure of the medications, I think those are relatively anecdotal comments and pretty uncommon. And I think the science and the technology has gotten a lot better in that area. Although I have to admit I'm not an expert in that area, but from what I understand, it has got improved. And that's one of the reasons that I guess California wants to do IV administration, is to avoid that problem, as Mike brought up.
Well, that's how Kevorkian, I guess you could call him the father of doctor-assisted suicide. That's how he did it. He threw his IV, put together, boom, that was it. But the first patient he ever did this to was just simply depressed intractably. And had she hung on a little bit longer with some of the modern methods that we have now for treating depression, she may still be here. That's another point that worries about the slippery slope here. Go ahead.
I was asked a question for Bob a little bit, and for you too, Nick. Mm-hmm. Have you thought about, you mentioned about how you would counsel a patient asking for assisted suicide. It was the question that Nick kind of started with. But how would you counsel your patients who are being given a terminal diagnosis about this if it was legal?
If it were legal?
Mm-hmm.
I think I would just give, if I were counseling, I counsel patients every day about end-of-life decisions. I have a very elderly population. We have a large demented population. I usually try to talk to patients with dementia while they're still competent and can understand the implications of what decisions they're making. And in Delaware, the options are limited. Certainly we talk about, do you want at-home, cardiac CPR, which, as you probably know, Mike, the benefit of in-home CPR is pretty dismal. It's not a large percentage of patients don't make it through
not like
life.
the movies.
No.
Pardon me?
It's not like the movies when you do CPR in reality.
It's not like the movies, and so I'll counsel patients, particularly on resuscitation type things, and what the family and the patient want to do if the patient becomes terminal. If medical aid in dying becomes legalized in Delaware, then that would just be another option that can be discussed with the patient. But again, it would be the patient's choice and the patient's decision, and hopefully they would talk to their family about it. And this is not a decision that's made lightly, or it's not like the patient decides on Monday, I want to do medical aid in dying, and on Tuesday they're getting medications, and on Thursday they're dead.
It takes a while.
Most of these patients get a prescription and don't even take the prescription. Look at the numbers in Oregon. I think it was over 500 patients last year got the prescription for medical aid in dying, and I think about 350 actually took the medicine. So almost half of the patients don't even take the medicine. But I think for the patient to have that sense of control in terms of their fate is an important one. And I think, again, I go back to patient autonomy. It's not for me to decide whether someone should do medical aid in dying or not. It's for them to decide. I'm here to provide education and information. They make the decision, and we try to help them implement that decision that they've made. And it makes me a bit angry when people say, well, I'm against medical aid in dying, and I don't think anybody else should have it either. That's fine for you to be against medical aid in dying, and if you don't want it for yourself, that's perfectly fine, and if I were your physician, I would support you 100% all the way. Mm-hmm. But if you wanted medical aid in dying and it was legal in the state, I would support that as well. The Medical Society of Delaware, a couple of years ago, changed their position from being against medical aid in dying to being neutral. And I think neutral is the best decision for the Medical Society of Delaware to take, because basically it encompasses all viewpoints. If we have physicians in the Medical Society and in the state that are very much against medical aid in dying, and that's perfectly fine. I think if they don't want to do it for themselves, that's perfectly fine. We have a lot of physicians, I think really a majority, that are in favor of allowing medical aid in dying to be an option. And to me, that's the correct way to do it. If you don't want it, you don't have to take it. If you want it, it's an option for you to take.
Okay. Mike, what do you want to say?
So I wanted to go back a little bit to the question I asked about the how do you counsel the patients, because it's a little bit unknown, I think, in terms of like what the standard of care would end up being with that. When you have 40 states where it's illegal, you don't really have a clear national standard of how to counsel people on this. But I kind of agree with Bob that this is something that when people are getting a terminal diagnosis, that if it's legal, is going to be part of the discussion of what their options are. That the oncologist is going to be saying something like, you could have medical aid in dying, you could have palliative chemo, you could have hospice. So it's going to be one of those discussions that people are going to be hearing about whether they want it or not, whether it's something that they would ever consider or not. And that's something that is important for people to realize, because it means that it's going to be affecting all physicians and all patients, whether or not they want it. Because just like when I bring up and I say, your mom's really sick, looks like she's having trouble breathing, we can put her on a ventilator, but maybe we also could just treat her symptoms. And they say, people get very upset, and they say, you're suggesting killing my mother. there's going to be that same conversation to be had, in the outpatient setting with these patients, where it's going to affect people who, not just the people who are seeking it, but people who are just getting counseling because they have a terminal diagnosis.
That's a good point. Now, how about euthanasia? What's the difference?
Yeah, I'll take that if you want.
You or Mike?
Yeah. So euthanasia is specifically when the physician or the healthcare provider is administering the medications. So what Delaware is considered, and it's part of medical aid in dying, but it's not assisted suicide. So we're talking in Delaware specifically about the patient must administer the lethal drugs themselves. In Canada, there's a association of MAID, so medical aid in dying assessors and providers, and they're doing both assisted suicide and euthanasia. And they have a white paper that is interesting because in order to avoid some of the problems that we talked about a little bit, they recommend that you consent anyone who you're going to do assisted suicide for to euthanasia. So right at the beginning, say, if we have trouble, we're going to start an IV and we're going to convert to euthanasia. So that it's linked in a lot of other countries. The same thing in the Netherlands.
They have Belgium too.
They published a paper from there in the New England Journal, and about 18% of the time they convert from assisted suicide to euthanasia. So it's linked, but here you wouldn't have that option.
Let's get the distinction here. They switched from medical aid in dying to euthanasia. In other words, they did not want to take the medicines themselves, euthanizing themselves.
Well, no. So what they did is these patients started out taking the medicines themselves, and oftentimes it was that they didn't die fast enough. So the physician's like, I think this isn't happening fast enough. I think they're suffering. I'm going to convert to euthanasia and make it happen faster.
Okay, I understand that. Okay, now, one last thing I want to bring up is the subject of the slippery slope. When does it become, I guess, unethical as they slip down the slope to ask to die? I have patients that just are terminally miserable. They do not like life. Life has not been good to them. They are not suffering from a significant amount of pain, but they just want to end it. Why does the doctor have to help them end it when they can end it themselves? I.e., let's say a patient just tired of living, like suicidal people that do it for no other reason, tired of living. And you can do it. You can go in your garage, shut the door, turn the car on, put a pipe in the back of your window, get a bottle of wine, and listen to some nice music, and you could just fall asleep from carbon monoxide poisoning. But why can't the patient do it unless they're unable to get that way? What do you think?
I think the differentiation, and most of the laws in the United States are modeled after the Oregon law. And the key is that you have to have a terminal condition of 6 months or less to live.
Okay.
So if someone's depressed, they would not meet that criteria. So they would not fall under the medical aid in dying criteria, and they would not be able to use this particular technique.
I'm not sure of this, but maybe you could correct me if I'm wrong. If you commit suicide, your insurance company doesn't have to pay for your life insurance, do they? Or do they? Not just I commit. Somebody just takes a gun to themselves because they're tired of living.
Yeah.
Does the insurance company pay for their?
I've heard that. I'm not an expert in that area.
I'm not either, and I'm just wondering. Do you know?
Sure.
I'm pretty sure you're right that for most situations, if you commit suicide, you're invalidating your life insurance policy. But this law in Delaware, HB 140, and because the state regulates insurance, it specifically addresses that, and it specifically says that the insurers are not allowed not to pay out because someone died through this.
Thank you guys for straightening me out on this, because I did not know the answer to that.
But
I didn't know that was not in the law. But go ahead.
But I wanted to go back a little bit to your question about the slippery slope, and your question about why does a doctor have to help someone who wants to die? And one of the things to remember when you say that anyone can commit suicide, oftentimes when people try to commit suicide, they fail. They end up in our ICU or something like that, rather than actually dying. So there's a lot of reasons why people would want, someone to make sure it worked, kind of. But there clearly is, when you look at other states, what you're seeing is a reduction in waiting periods. You're seeing an expansion to populations that it didn't initially start out with. And actually, Thaddeus Pope, who is a professor of law at I think in Minnesota, who Bob mentioned, is a good person to read on some of the ideas of the expansion. He has ideas that, for example, like that the ADA should require healthcare providers to administer drugs through a PEG tube if the patient can't. That would be a violation of the Americans with Disabilities Act if you're not doing that. He has an idea that we should be able to put this in our living wills. So you could have like an advance directive that said, if I had dementia, I would want to be killed, and have that sort of arranged before. So he has a lot of ideas on how this will expand in the future.
What is that book? Can you quote it again?
Thaddeus Pope. Pope.
I have a link in my references that you can...
He has an article on the American Bar Association website about his, your options for end of life, or your options for something like that. And he has like a what's next for MAID, where he lays out some of his, future directions for it.
Okay.
But you certainly see, people with, psychiatric disease who are suffering intractably, and in the Netherlands, for sure, we've seen assisted suicide and euthanasia used extensively in that population, and we've seen in Colorado, it used for the anorexia nervosa population, and it's very applicable with the current law because these people are dying of starvation, right? So you can clearly say this person has a 6-month prognosis, they're dying of starvation, and proceed with that. And I could read you a little bit from the paper that it's Dr. Gardina wrote in the Journal of Eating Disorders. If you Google terminal anorexia nervosa, 3 cases and proposed clinical characteristics. And the story of Alicia, who's actually one of the authors posthumously, because she did end her life with medical aid in dying. And she talks about how Alyssa's parents, one of whom actually is a physician, asked whether any treatments remain that might yet change the outcome of her course, specifically noting that Alicia had not completed a full residential eating disorders program, never fully restored weight, never tried new psychedelic options such as ketamine, hadn't had a feeding tube. She goes through the different reasons why they're not there. But if it's worth reading that paper, because you see the care that was taken with it, how they went through all these different options, worked through why they weren't going to do them, got lots of consultations, and ultimately led to this. So it's definitely something that you're not going to see that as your first case in Delaware, but you'll see it eventually.
Got it.
I think the slippery slope argument really has not been seen, in my opinion. If you look at Oregon's been doing this for 25 plus years, and we haven't seen the slippery slope in Oregon. And I'm not aware of the slippery slope occurring in the other 10 jurisdictions in America where this is legal. So I think it's a common, point that's brought up by people opposed to medical aid in dying, but in reality, it has not been seen. There may be some anecdotal reports, but the majority of these patients that go through medical aid in dying do it according to the legal ramifications and because of their own choice. And again, it gets back to me to be a patient autonomy, a patient choice issue. If that's what you want, you should be allowed to do it. We shouldn't have people who are against medical aid in dying say, no, you can't.
Okay.
What I mean by the slippery slope, to be clear, is expansion to patients that maybe weren't initially thought of when you were passing this law. So, for example, the anorexia patients in Colorado are an example of that because you might not have necessarily been thinking of them when you passed the law.
Okay.
The same thing in Oregon. one of the things, the dementia patients are a problem. Like you go to the hearing on the bill, and, someone stands up and says, my dad had this terrible dementia. His life was horrible. This would help him so much if he could have ended his life like this. But he doesn't have capacity, right? So what they've done in Oregon, in some of the cases, they've said, okay, stop eating, stop drinking. You have capacity now. You don't have a 6-month prognosis, so you're not eligible. But if you stop eating and drinking for a while, then you'll start to starve, and you'll have a 6-month prognosis, and then we can give you medical aid and dying.
But won't they die anyway if they stop eating and drinking?
They will.
So
but
they're
take
allowing
longer.
themselves.
They're losing
Okay.
that. They're losing that control.
Okay.
And they're if they try to starve themselves all the way. So.
Wow.
If you look at the Oregon data, 66% of patients who went through medical aid and dying had cancer.
Mm-hmm.
10%, 11% had neurologic disease. 10% had cardiac disease. About 7% had respiratory disease. Endocrine was just 2%. GI disease like liver was 2%. Infectious disease like AIDS was only 0.5 disease. And other illnesses were 1.9%. So if you look at the stats, the vast majority of these patients have serious terminal conditions. And this is after 25 years. And to me, it appears that these patients are being treated appropriately.
Okay. Gentlemen, this has been a very good discussion. I'm quite pleased at the way things are. I'm mixed about this issue because I rack it in my brain.
Well, are you mixed about it for yourself, or do you think patients should not have a choice as to how they want to end their life?
Myself.
Okay, well, that's fine.
My philosophical self.
I think everybody is mixed. This is not an easy decision to make, but I think what I would like to hear you say is that you're for patient autonomy, and if someone else wants to have this, they should be allowed to have it.
I am for patient autonomy. It was without a doubt about that, and if requested to do so, I may not participate in it, but I can find individuals that would, or other doctors. I have this whole law that's being thought about and being created has just made me view my ethics in many different ways, and at times,
Well, that's probably a good thing, Nick.
I guess it is. I guess it is, but I wish I had an easy answer. That would be nice to know. But yes, I think patient autonomy is probably one of the best reasons to do to allow this to occur. More than my religious background, nothing to do with it. I'm sure of that. My Hippocratic oath was what hypocrisy was in what year was that?
So the infamous Hippocratic oath, which was written 2,000 years ago,
yes,
probably doesn't,
exactly.
And it's been revised multiple times, and I don't know how it applies to today's world of medicine, but the statement that you always hear is "do no harm."
Correct.
And in my mind, if you're not giving a patient their choice and giving them autonomy, that to me is maybe one of the greatest harms you can do for a patient. So if you want to do no harm, let the patient decide.
Understandable. I guess the argument for autonomy is a strong one.
I have a couple comments on that as sort of the con side, and with the feeling that legalizing assisted suicide or medical aid in dying is going to cause harm. And I think it's causing harm to our most vulnerable patients. And when you talk about medical ethics, I think it's important to think about it in sort of a systematic way. And the way I think about it is, first you have to say, what are we actually capable of doing? What are sort of the medical facts of the situation? And how does this affect the patient, the family, other patients, and society at large? And you have to look at it. Autonomy is one principle of medical ethics. It's one of the core principles, and it's important. Beneficence is also a core principle that's important. Non-malfeasance and justice. And justice is the area where this really falls down. And the fact that you have patients who are concerned about being a burden, patients who are concerned about their ability to afford treatment, and you have a healthcare system that is not only not meeting the needs of patients, as we've been talking about how we have the shortage of palliative care doctors. We're not doing a good job managing the symptoms. We have insurance companies denying medical therapy that would be palliative, but offering assisted suicide. justice is one of the big ways this falls down. Justice, and also it falls down on non-malfeasance and beneficence. So you have, and it falls down in the impact that it has not just on one patient, but when you look at the rest of society. And especially on sort of a legislative and sort of a policy position point of view, the justice point of view really has an important weight to take in your decision-making. So,
Mike, when you were giving your initial comments about this whole issue, one of the things I kept thinking about are the difficulties with the American healthcare system. America has is one of the only developed countries in the world that doesn't provide free medical care to its population. We have the most costly system in the world. We seem to have the worst results of most developed countries in the world. And maybe rather than saying you're against medical aid and dying, maybe we should work on improving or doing something with the American healthcare system.
Oh my God, that is 100% correct. We all know it's broken. We all know sort of why it's broken. And we have to also blame the population of America, in my opinion. We eat too much, we drink too much, we smoke too much, we do drugs, we don't live healthy lives. And that is partly why we are 38 in the developed countries when we have everything that's the best. Now, how do I, as a physician, tell that morbidly obese person that you're going to die? I do anyway. You're killing yourself. How do I tell them that? And when on every corner there's a McDonald's or some fast food place or something, the foods in this country are just causing our death.
Well, I think you're correct in that the American diets are certainly not the best. And one of my pet peeves is that I've read somewhere that 70% of the processed food in America has high fructose corn syrup, which in of itself is a killer. But I also read an article that said that Americans generally don't use any more health care than Europeans do, but that our health care is a lot more expensive than Europe. And I remember reading.
Know how that plays into it.
If it costs $3,000 to get an MRI scan here and $300 in Italy, there's going to be a difference in overall healthcare expenditures.
But the thing that with this related to this that I would say is you have the broken healthcare system, you have the person who can't afford the care they need, and you throw into this, you say, I'm not going to do anything to help you get the care that you need, but I'll help you end your life, and I'm not going to do anything to help you not lose all your money at the end of life, except if you're willing to take this option. It's really cheap, and it won't. Then you'll have that inheritance that you'll be able to give the house to the kids.
Ooh, good point.
If you take this way, but if you wait and you go through hospice, you might not have the house anymore to give to the kids. So you're kind of offering them. It's kind of an indirect form of coercion.
Oh, there's a last point put in. What do you say to that, Bob?
Well, I think, again, look at the statistics, though, and Oregon probably has the best ones. And I think as you mentioned, it's really loss of control, personal feelings about. I forgot exactly what the exact Oregon comments were. You mentioned it before, but I think the burdensome was in the 40% range, 40 to 50% range, but the loss of control and having a say in the end of their life was much more important. I should bring it up. You just had it.
45. I gave you the papers. It was 45% that said that they don't want to burden their family.
47% for all the years, and it kind of varied somewhere in the 40 to 50% range the whole time.
And 25% that were for pain. Yeah. That's 25% request for pain.
Right. But if you look at,
but really, that's 25% who maybe weren't getting the right treatment. Because really, no one should not have their pain treated.
We don't know that. Yeah. Okay.
So the thing, I think, let's see, it was.
Go to that table if you want to find it.
The table one.
Yeah, keep going down. You'll get the list.
Okay.
be 14, page 14. There it is.
There it is. So loss of autonomy was 91%. Less able to engage in activities making life enjoyable was 88%. Loss of dignity was 63%. Loss of control of bodily functions was 46%. And burden on family, friends, and caregivers was 43%.
Only 25% for pain control.
5:06 p.m.
Inadequate pain control 2023 was 34.3%.
Well, my stat must be off a bit, but it said 25 where I read it. Okay.
But the bottom line is loss of autonomy, less ability to engage in activities making life enjoyable, and loss of dignity were the top three reasons.
Okay.
And 8% on the economic issues is really concerning, though.
Agreed. Okay. Very interesting discussion, gentlemen. I guess we have exhausted it, but we could probably continue this argument and discussion for hours. But this leads me into an advertisement for our future podcast. I've been working on why and how and what do we do about the broken medical system. It'll be first from the doctor's perspective. I'm working on the second part. I've fit the first part. The second part is going to be the hospital systems and how they function in the system, and lastly, the insurance company. So stay tuned for that, everybody. But this is Dr. Nick Biasotto finishing our discussion about medical aid in dying, which I believe was a very interesting discussion. I want you all to think about it. And doctors out there, maybe it's time to approach your patients early in their life about their desires and their hopes in the future for whatever we need to help them with, including dying. This is Dr. Nick Biasotto signing off from the Medical Society's podcast, Delaware Health Care Reality. And I thank our guests, Dr. Bob Varipapa and Dr. Michael Vest.
This has been Delaware Health Care Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Health Care Reality is Mark Thompson. Delaware Health Care Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.